So hi again. Back to the cholinergic drugs. Another type of drugs act on the same receptors of the acetylcholine and are known to act against it. They are called cholinergic antagonists. The cholinergic antagonists are then agents that bind to the cholineceptors. Remember that the cholineceptors are of two types, muscarinic and nicotinic receptors. The fact that the cholineceptors or the anticholinergic drugs acting on the cholineceptors prevent the binding of the endogenous acetylcholine neurotransmitters. The cholinergic antagonists are of three types, depending on the site of their action. If you remember this scheme, you have the nicotinic receptors present at the level of ganglia, and you have the nicotinic receptors present also at the level of the skeletal muscle in the somatic nervous system. In addition, the muscarinic receptor is present on the parasympathetic division of the post-ganglionic neuron. Usually, the site of action of the anticholinergic neuron are then to be the ganglia, and they are called ganglionic blockers, are the neuromuscular junction, and they are then called the neuromuscular blockers, and the muscarinic receptor, and they are called antimuscarinic drugs. So using these sites of actions, that we can classify the anticholinergic drugs into first two types according to on what type of receptor do they act. First, the first one is the antimuscarinic drugs, and they are also known to be atropine-like drugs, or also called parasympatholitics, since the muscarinic receptor is only present on the post-ganglionic level of the parasympathetic division. While the anti-nicotinic drugs are of two types. Those that act at the level of ganglia, and they are called ganglionic blockers, and the others that are present at the neuromuscular junction, and they are called neuromuscular blockers. I'm gonna start by the antimuscarinic agents that are also known to be anticholinergic drugs. The prototype of the antimuscarinic agents are the atropine and scopolamine that are naturally occurring antimuscarinic agents. Both agents blocks, of course, the muscarinic receptors in the parasympathetic division as shown in the past figure, and they cause then the inhibition of the muscarinic receptor. They can also block few exceptional sympathetic neurons that are cholinergic neuron and those that innervate salivary and sweat gland. But this capacity to block sympathetic neuron is due to the concentration given of the drug. The antimuscarinic drugs have also little or no action at the skeletal neuromuscular junctions or the autonomic ganglia, since the receptor present there is of nicotinic receptor. So because they do not block nicotinic receptors, they are beneficial in a variety of clinical situations, such as, for example, patients who are using antihistamine. The antihistamine may have also an antimuscarinic activity. The antimuscarinic agents are then classified using four types of classification or four criteria. First, they are natural. Some are natural alkaloids, and they are of two types, the atropine and the scopolamine. Another classification is depending on how are they synthesized. Some of them are semi-synthetic derivatives, others are synthetic compounds. Examples of semi-synthetics, you have the tiotropium, you have the ipratropium, and you have also the atropine methonitrate. The synthetic compounds are classified according to their mode of action. Some of them are mydriatics, they treat mydriasis. that is a dilation of the pupil. Examples, you have the cyclopentolate and you have the tropicamide. Others act as anti-secretory or antispasmodics, and they are also subclassified into three types: those that are quaternary ammonium compounds, others tertiary amines, and others used to treat Parkinson's disease, and they are the anti-Parkinsonian drugs. The last classification is the miscellaneous classification, and it includes the antihistamines. Usually, all antimuscarinic agents blocks competitively the muscarinic receptors. The atropine and scopolamine blocks all M receptors starting from M1, M2 to M5, while others are selective. For example, if we took the tertiary antimuscarinic agent, they do not block nicotinic receptors. They only block muscarinic 1, while the quaternary amine compounds blocks the muscarinic as the nicotinic receptor at the same time. Some examples are taken. I'm gonna start by the atropine, which is a naturally occurring tertiary amine alkaloid. It has a high affinity for muscarinic receptor. As you can see, it competes competitively with the acetylcholine. So the atropine, when it is provided at concentration higher than the acetylcholine, then it will occupy the muscarinic receptor and kick the acetylcholine out of this binding. It acts both centrally and peripherally. And the general actions of the atropine lasts for about 4 hours, except when it is given in ophthalmology and when it is provided topically in the eye. It lasts a few days. The neuroeffector organs have also variety in their sensitivity to atropine. The greater inhibitory effects are done on the bronchial tissue and the secretion of the sweat gland and the salivary gland. Many pharmacological actions of the atropine. First, it acts at on the central nervous system. When the atropine is provided at low dose, it doesn't cross the blood-brain barrier. When it is provided at high dose, it produces central nervous system stimulation. The atropine stimulates also many medullary centers. Example, it stimulates vagal neuron, respiratory neuron, and the vasomotor. It depresses also the vestibular excitation. Note that the vestibular system is a sensory system that functions to detect head motions and position relative to our gravity. The atropine has also an anti-motion sickness property. It suppresses as well the tremor and the rigidity that a Parkinsonism have it by blocking the action of the cholinergic neuron overactivity at the level of basal ganglia. Regarding the cardiovascular system, in the heart, the atropine binds to the M2 receptor and blocked it in the sinoatrial node and AV node and leads to a tachycardia. It can also block muscarinic autoreceptors present on the vagal neuron, ending and causing an augmentation in the release of acetylcholine that lead to a predominant bradycardia, and finally that end with a tachycardia. At the level of blood vessels, the atropine, as you can see, act by inhibiting the effect of the acetylcholine that causes vasoconstriction, while in the presence of atropine, a vasodilation will be noted. So when it is given at high dose, it has a direct vasodilatory effect, and it also enhances the release of histamine. That's why we can see a vasodilation that may lead to hypotension.